It's a pleasure for me to be here again in Brazil, and I want to thank all the members of the Brazilian Pediatric Neurosurgical Society, especially Ricardo, José, and Sergio Cavallero. We will speak about shunt infection. It's a major problem when we talk about complication in shunts, and when we speak about what are the main improvements in the management of hydrocephalus against early diagnosis, radiological investigation, better knowledge of mechanism, quality of material, surgical technique, and we see that we have less complication than before, of course. But when we speak about modern shunt surgery, we see that the number of mechanical complications has decreased significantly in the last 20 years. Unfortunately, when we see the literature, shunt infection remains at the same level. And the main question is why? Why we have this disturbance? When we see the literature in 2014, collecting more than 800 shunts in the literature, we see that each shunt infection rate is between 0.7 to 35%. Even now in recent papers, we can have this high level of shunt infection. And the average of infection is between 6 to 8%. And we see that the number of infections decreased progressively in the recent years, but it remains even now in the high level. When we see that the infection rate in the large cooperative studies is between 3% to 12%. Consequently, it's a too high level for me. And if we want to classify the shunt infection, we can have wound infection. That means at the level of the shunt tract, at the level of incision. We have also CSF infection. That means meningitis and or ventriculitis. The shunt system may be infected itself with minimal signs of CSF contamination, for example, purulent exudate into the material or at the level of the shunt. And abdominal complication, because I am convinced that abdominal complication in most of the cases is clear a shunt infection. And here you see the typical effect of ventriculitis. For example, in a 2-year-old shunted patient with pus inside the ventricles, before and after injection, you see the ependymal layer is well visualized. We can have also at the level of the tip of the ventricular catheter an abscess into the brain, or as you see here, ventriculitis, infection at the level of the reservoir, infection at the level of the ventricular catheter, and ventriculitis, as you see here. And here you see also a typical aspect of the ventriculitis in a small baby with trapped fourth ventricle, or this sepsis, multicystic and multiloculated hydrocephalus. That all the aspects of shunt infection at the level of the brain and at the level of the ventricles. What are the main organisms when we speak about shunt infection? In most of the cases, is the Staphylococcus speris, coagulase negative, and Staphylococcus aureus. That means that if it is Staphylococcus, that means in most of the cases it's a colonization of shunt by skin flora, and CFM acts as a foreign body. When this shunt infection occurs, in the majority of cases, is during the first month or the second month. But that is what we see in most of the cases. In our material, in our recent studies, shunt infection occurs in the first 2 months after shunt infection, shunt insertion. But we can have late shunt infection. They are quite rare. In this study published in 1999, is between 12.7% in our material, among more than 1,000 patients, the infection, late infection, occur in 1.3%. But to summarize, in most of the cases, the shunt infection occurs in the first 2 months after shunt infection. When we have a shunt infection, there are many questions, controversies. What are the main problems? What could be the treatment of shunt infection? The consequences, the costs, the causes. But what is the most important is how to prevent the shunt infection. That is the main major problem, and we will try to classify this prevention. What are the risk factors of shunt infection? It may be the cause, the clinical condition of the patient, the age, operation time in the day, duration of shunt operation, the number of persons, what about the shunt material, the presence of postoperative CSF leak, and sometimes the economical level of the medical center. The cause of hydrocephalus are very clear. In most of the cases, is when we have a hydrocephalus with intraventricular hemorrhage, and you see in the old publication of Volpe, the shunt infection occurs in 45% of the cases. In BOOP, 13%, in Boyden, 50%. Also, the cause of hydrocephalus myelomeningocele can accompany with infection in most cases, and of course, meningitis. That are the 3 main causes of shunt infection: hemorrhage, myelomeningocele, and meningitis. And here you see what occurs when we have a myelomeningocele infection in near 20% in the MEST publication. Here also you have another publication with a great number of cases. You see that the myelomeningocele and post-hemorrhagic are the main causes of shunt infection. Also, the age of the patient is a risk factor for shunt infection. And as you see in this publication, you see that the infection occurs more frequently in children than in adults. In children than in adults. That is true in most of the cases, especially shunt infection is more frequent in the neonatal period. What about the shunt material? Is it a risk factor for shunt infection? It's difficult to define this, but we need to speak about any type of material. And the type of material has for us little infection or mechanical complication and on shunt infection. But we need to know that we need a careful selection of the material before surgery. We know the age of the patient, we know the etiology, consequently we need to reduce the time of operation, consequently we don't want to lose time, and before surgery, how we need to select the material. Never we need to test the valve, that is risk of infection in all the statistics. And we need to open the sterile packaging at the very last moment. That means few seconds before inserting the material, not half an hour or 1 hour as I have seen in many departments. What we need to avoid is all these things. This type of material, the reservoir, all this suture, that is the main cause of infection. We need to avoid all this type of material. The best to avoid complication is this type, one ligature between the ventricular catheter and the valve, and nothing more, and no connectors. Connectors are a cause of a shunt infection in many series. Also, the type of material of valve has no influence of shunt infection. And here you see in this series with more 10 centers, the infection rate is 8.4%, is totally independent of the type of material. And even with the programmable valve, we can have infection. In this series published in 2000, you see the shunt infection rate is 8.5%. Consequently, for us, the type of valve, the type of material has no influence on the infection rate. And here is an interesting paper by Benjamin Worf, published in Uganda, using aqui valve or the Chabra shunt. Very expensive one, no expensive one. And you see the infection rate is exactly the same. 11 with the Codman, near 10% for the Chabra. Consequently, no difference. What about antibiotic impregnated shunt catheter? I think that it has an influence. And you see that between these two series, shunt infection in impregnated catheter is 12%, with impregnated catheters only 1.4%. That's been described in many series, and you see this in this publication in 2019, using more than 3,000 patients. You see there is a significant differences using antibiotic impregnated catheter or not antibiotic catheter. And you see this publication in 2008, published by Tamburini and Di Rocco. You see differences between the standard catheter and antibiotic impregnator, significant differences in the two types of therapies. It's clear in this Lancet publication in 2019, antibiotic impregnated shunt could prevent hydrocephalus infection and save millions of patients. Of course, post-operative CSF lag has effect, and you see in this series when you have a CSF leakage at the time of shunt implantation or a few days later, the shunt infection rate is quite high. We see in our series of more than 3,000 shunt implantation, we see that 60% of infection occur 1 month after surgery, and 80% 6 months after surgery. What is the consequences of this? Is shunt infection is an operative complication, not after implantation, is during the operative period. And it's clear that the technique of implantation allows to eliminate or to reduce not only mechanical complication, but shunt infection. In the preoperative period, we need to see what is the clinical condition of the patient, general condition, if the child is infected or not, and the skin condition. We don't shave the patient. Shaving can be dangerous, especially if we shave the patient few minutes before shunt implantation. In the last 30 years in our department, we don't shave the patient and we don't have more infection. And skin preparation also is important. If we have an infection or like this, we need to insert the shunt in the other position, but it's very important to assess the clinical condition of the patient before shunt implantation. And we will speak later on about this. We don't give antibiotics before shunt insertion. Shaving of the scalp is most likely a risk factor in the prevention of shunt infection. What we use is only we shave at the time of skin incision, as you see here, here, and here. What happens in the theater and schedule timing? Shunt implantation must be performed in the morning before other operation. That has been mentioned in several series. If you implant a catheter in the afternoon or in the night, of course, if it is an emergency, you cannot change this. But if you have a programmed schedule, shunt implantation must be done early in the morning and as first operation. If you are head of the department, it's easier to indicate a shunt insertion in the morning. If you are a resident, sometimes it's impossible. We need to start with the youngest patient, premature or infants before older patient, and the length of operation is very important. We will speak about it. The duration of the implantation is related with age. It's easier to make the insertion of the shunt in the children than in adults. If it is a first implantation or revision, we have more complication of shunt infection if it is a revision. And of course, if we have operative complication during shunt insertion. But the main aspect is the expertise of the neurosurgeon. If you do 3 or 4 shunt insertion in the year, of course, we will get problems. If you do 200, 300 operations a year, the number of complications will be reduced. What about theater staff? 4 persons only. The surgeon, his assistant, the anesthetist, and the nurse. No scrub nurse. We don't need a scrub nurse for shunt implantation. What I say is that I'm trained in US and in Canada. What I have seen is that the material and all these persons were preparing the valve and all the instruments. Half an hour, sometimes 1 hour before implantation. That is very dangerous. The material must be opened by the neurosurgeon and his assistant. We don't need a scrub nurse. We need only 1 nurse, and what we need to avoid is this. We put a shunt, and you have all these persons looking for the surgery. We need to cover the material during all the procedure in order to avoid contamination by the air. Consequently, during surgery, we need to cover all the material as you see here or you see here. That is very important. No touch technique, that has been mentioned in many protocols. We need to use gloves and double gloves, one at the beginning, and when you insert the valve, you make another one. And as I mentioned previously, abdominal complications in peritoneal shear are mainly, in my consideration, a infection complication. That has been mentioned in some states, but for me, it's not a problem. It's a complication related with infection. And when we have an ascites, when we have a cyst like this, we need to treat the patient as a patient infected by the material. What we need to do when we have abdominal complication in shunt implantation, we need to change the peritoneal drain position, remove the material, insert an external drainage, and sometimes to perform a ventriculo-atrial shunt. What about antibiotics? Antibiotics before implantation is not important. We don't need to do that. Also, we don't need to give antibiotics after implantation. Since we have a very low infection rate, what we use is during the operation, intravenous injection during anesthetic induction with, for example, kefandrol 50 milligrams per kilo. In case of shunt infection with ventriculitis, we don't recommend intraventricular antibiotics. That for us is not useful. It can be dangerous at the epidermal layer, especially during a long period of time, and has been calculated by pathological studies that intraventricular antibiotics not only is not necessary, but you can destroy the ependymal layer. Shunt infection can be best managed medically without removal of the shunt. I don't think that is true. We don't need also to put the material in a bath of antibiotics before implantation. I don't think it's important. We don't use this in our statistics. What is the management of shunt infection? We need to remove the shunt, of course, all the shunt, ventricular catheter, the valve, and the peritoneal catheter. We need to insert an external drainage, intravenous antibiotics during 5 to 1 week, and after 3 sterile CSF culture, we replace ventriculoperitoneal shunt in the contralateral condition. The total hospital stay is between 13 to 20 days. It's what we do in near all the cases. External drainage, as you see here, and it's important to have all these techniques to avoid CSF leakage and externalization of the ventricular catheter. In developing countries, when we insert an external drainage, we raise 2 problems. The infection rate, and many times when I go to Africa or Eastern Asian countries, when I speak external drainage implantation, many persons say, oh, it's dangerous in our part due to the infection and the cost, because sometimes we need to replace the material 1 time, 2 times, sometimes 3 times, and it costs. That is the main problems in developing countries. But the complication rate, especially infection in external ventricular drainage, may be significantly reduced with the correct technique for implantation. Consequently, we need to use the same protocol. External drainage must be implanted in the operating room, never in the intensive care unit. We follow the same protocol as for VP shunt. We manage the material must be managed by the neurosurgeon during the following days. And if we need to maintain the external drainage for more than 2 weeks, we need to change all the material every 15 days, even if we don't have infection. In the study of Ashok, published in 2000, he studied infection rate in more than 8,000 external ventricular drainage. What he shows that the number of infection is between 6.7%. It's exactly the same infection rate we see in the internal implantation, as I mentioned previously. Consequently, with a good protocol, as we use for internal shunt, peritoneal shunt, we can avoid the majority of infection. And in our material, infection rate in external drainage is 3.2%. The consequences of shunt infection are important: mortality, morbidity, and the cost. And mortality is clear, is more important when we have infection. Shunt infection is associated with a long-term risk of mortality greater than 30%. That is a double that observed in children without infection. That has been mentioned in several series, as you see here. Here in this series, comparative studies, you see the mortality rate is 10%. Consequently, that is a major complication of shunt infection. Also, morbidity, because when you see what happens after infection at the level of the ventricles, of the level of the brain, you can have psychomotor retardation, neurological impairment, intellectual deficit, visual problems, and seizure. And the seizures are quite frequent after shunt implantation. Consequently, the consequences of shunt infection are dramatic in many, many cases. And here you see what you can have in case of shunt infection, and all this complication leads to different treatment. Shunt infection and epilepsy. Many publications like this. In our personal experience, shunt malfunction, especially shunt infection, induce significantly epileptic seizure during follow-up. The cost has been studied, especially in US, especially in UK, and here you see the cost of infection in US in the recent series. It has been published in 1995. Shunt infection costs around $30,000 US. If we avoid shunt infection, one shunt infection less is equivalent to 50 standard shunts or 15 high technique shunts. Consequently, in many departments, the consequences of shunt infection is very important. And in this PARC studies in 2011, you see that in average, a shunt infection costs $7,000 to near $50,000 US per patient. Consequently, we have seen this. Again, shunt infection is an operative complication. You see our publication before our protocol, before 1983, we have per patient 9.6% infection, per procedure 3.5. Since we start our protocol, per patient now we are 1.9% and 1.3%, with now near more than 2,000 children. Consequently, it's clear that we avoid this complication. We have published this protocol in Journal of Neurosurgery in 92. And what is curious in the literature, most of the papers dedicated on shunt material, especially valves, very few papers, very few on technique. It seems that shunt complications are a fatality, and part of the shunt procedure. And with limited percent noir, with no touch technique, with double gloves during surgery, with experience as neurosurgeon, the duration of the procedure is important. With prophylactic antibiotic, we can prevent shunt infection, and surgical technique is the most important. That is clear for us, since so material. When we speak about modern management of hydrocephalus, it's clear we have less complication in shunts and especially less infected shunt. My conclusion is shunt infection is not a fatality. It can be less than 1% with this type of protocol.